Well, if you look at the human head, we sort of naturally tend to organize our understanding of it around the sensory organs. You think of the orbit of the eye and you're looking
Yeah.
at this perfectly designed, highly specialized lens capturing light.
Right. It's very contained.
Exactly. Or, you look at the ear and you see this incredibly intricate translator, like a mechanism dedicated entirely to turning mechanical vibrations into electrical signals that the brain can actually decode.
Yeah, and both of those structures, crucially, they are housed within protective bony vaults. They are quite isolated.
Right. They have this neat, isolated logic to them. But if you move just slightly inferior and posterior, like right to the angle of the jaw, you step into a region that just completely defies that logic. Welcome to a conceptual synthesis of Chapter 11 of the textbook of Head and Neck Anatomy by Hyatt and Gartner. We are doing a deep dive into the parotid bed today.
Oh, it is a fascinating area.
It really is. And if the orbit is a lens and the ear is a translator, then the parotid bed is, well, it's a crossroads.
It is the absolute definition of an anatomical transit hub. And unlike that protective, quiet isolation of the orbit you mentioned, this area is dense.
Yeah.
It is remarkably alive, and frankly, it is dangerously interconnected.
Yeah.
The deep dive we're doing today is really meant to be a companion to the text. We're not just going to, list off anatomical structures like reading a telephone directory.
Yeah, absolutely not.
The mission here is to build spatial and functional mental models. So for those of you listening, whether you are a medical student in your early clinical years, a surgical trainee, or maybe a clinician just revising your applied anatomy, the goal is to map out how these structures relate in three-dimensional space.
And critically, why those specific relationships dictate clinical outcomes, right?
Okay.
Because as the text anchors it, anatomy is the study of structure in service of function and how that structure shapes disease, intervention, and outcome. So we are going to move logically from the rigid structures that define the space to the dynamic functions occurring within it, and finally to the actual clinical reality.
Yeah, because in the parotid bed, you're dealing with a massive salivary gland actively secreting fluid. You have a major cranial nerve branching out to literally give the face its identity.
Right.
And you have major arteries dividing into streams that supply life to the head. Everything has to pass through this one highly congested intersection.
It's just a chaotic topography. I mean, if you are going to operate here, or even if you are just trying to diagnose facial pain in a clinical clinic, you absolutely must know where the wires and the pipes are buried.
100%.
Yeah.
If you misjudge the depth or the relationship between these structures, the consequences for the patient are immediate and severe.
So let's build the boundaries of this crossroads, the anatomical framework. Because if we are referring to the space as a bed, we need to define the walls. And I want to start with the bone and the tough, fibrous muscle that creates the perimeter. Because my understanding is that the parotid bed is an incredibly irregular space.
It is entirely irregular. And more importantly, it is rigid. Anteriorly so. The front wall of this space is defined by the ramus of the mandible.
Okay, the jawbone.
Right, that vertical portion of the jawbone that extends upwards to articulate with the skull.
Yeah.
You also have the posterior border of the masseter muscle attached right there to it. Then, posteriorly, the back wall is formed by the external acoustic meatus, the bony canal of the ear, and the mastoid process of the temporal bone.
Which is that hard, bony prominence you can palpate, like right behind your earlobe.
Exactly.
So if I'm tracing this on my own face, I've got the angle of the jaw and the back edge of the ramus in the front. And I've got the ear canal and mastoid bone in the back. It's sort of a wedge-shaped gap. What happens as we push deeper, towards the midline of the skull?
Medially, the wall is formed by the styloid process.
Ah, right.
Yeah, this is a sharp, slender, almost needle-like projection of bone extending downwards from the base of the skull, just anterior to the mastoid process. It basically creates this deep, unyielding pillar. And inferiorly, the floor of this bed is defined by the superanterior border of the sternocleidomastoid muscle.
The big one running down the neck.
Right, running diagonally down the side of the neck. And also the posterior belly of the digastric muscle, which sweeps up towards that mastoid area.
I just pictured this space like an irregularly shaped, completely rigid suitcase. You have these hard borders, the ramus, the mastoid, the styloid process. You cannot change the dimensions of the bones.
No, you can't.
And the taut fascial layers over the muscles form these really unyielding walls. It is a fixed volume.
A fixed volume is the crucial concept here. And that fixed structural volume is exactly why the main occupant of this space, the parotid gland, is shaped the way it is.
Right.
The parotid gland is the largest of our three major salivary glands. But because it has to pack itself into this highly irregular, rigid suitcase, it is not a neat spherical organ.
Oh.
It's heavily lobulated and molded right into the available crevices.
It essentially just pours into the space, conforming to whatever structural boundaries are already there.
Yes. And as it develops, it forms these deep, finger-like projections that reach into the fascial planes of the deep face. Superficially, the gland extends upwards over the masseter muscle, reaching all the way to the zygomatic arch.
The cheekbone.
Yeah, the cheekbone. Sometimes, as the text actually notes, a small detached piece of glandular tissue called an accessory parotid gland sits anteriorly over the masseter.
Oh, wait, totally separate from the main body.
It's completely separate, yeah. But it still empties into the same duct system.
Okay, so that superficial spread makes sense, but the text places a lot of emphasis on the deep extension. The gland doesn't just sit beneath the skin, it wedges itself inwards.
It does. Medially, it forms a wedge-shaped lobe that dives deep towards that sharp styloid process we talked about. It slips through the stylomandibular tunnel. It can even extend far enough to sit between the medial and lateral pterygoid muscles.
Wait, let me bring in some context from Chapter 12 on the deep face for a second. The medial and lateral pterygoid muscles reside in the infratemporal fossa. That is a really complex, deeply situated space filled with the muscles of mastication.
Yes, it is.
So you were saying the parotid gland, which we normally think of as just the superficial cheek structure, is actually sending little fingers of glandular tissue deep into the muscular spaces of the infratemporal fossa.
It absolutely does. And this is exactly where the topography translates into immense clinical significance. These deep, finger-like lobes are what make the parotid gland so intimately associated with the critical structures passing through the region.
Right.
The gland isn't just sitting neatly on top of the facial structures. As it develops, it wraps its lobes around nerves and blood vessels. It engulfs the transit lines.
It's like pouring expanding foam into a junction box full of cables. The foam just expands and hardens around everything. The cables are entirely embedded within the matrix of the foam.
That analogy perfectly captures the spatial reality, which means any pathology of the gland or, any surgical attempt to remove the gland immediately involves all of those embedded cables.
Well, let's look at the infrastructure contained within this expanding foam. We need to move from the structural framework to the functional integration, the movement, the flow, the innervation.
Right.
I want to start with the plumbing. The defining purpose of a salivary gland is to manufacture saliva and deliver it to the oral cavity. How does the parotid gland navigate this dense topography to actually get its product to the destination?
The delivery system relies entirely on the parotid duct, historically known as Stenson's duct. It emerges from the most anterior, superficial portion of the gland. From there, it travels straight forwards, essentially horizontally, right over the lateral surface of the masseter muscle.
So it's quite shallow there.
Very shallow. It sits very superficially here, just deep to the skin and the subcutaneous fat.
I'd imagine that superficial positioning makes it quite vulnerable, though. Like a deep laceration to the cheek, say from a knife wound or shattered glass in a road traffic accident, could easily sever that pipe.
Oh, absolutely. It is a common presentation in maxillofacial trauma. Because it crosses the masseter so superficially, accompanied by the transverse facial artery, any penetrating trauma in that specific horizontal plane is highly suspicious for a duct laceration.
Wow.
But its path gets particularly interesting when it reaches the anterior border of the masseter muscle. The duct doesn't just keep going straight, it takes a sharp, nearly 90-degree medial turn, diving deeply into the buccal fat pad of the cheek.
And from there, it has to get into the mouth.
Correct. It pierces straight through the buccinator muscle. The buccinator forms the muscular wall of your cheek. The duct punches through the muscle fibers, runs for a short distance just under the oral mucosa, and finally enters the oral vestibule at the parotid papilla.
Which is located exactly opposite the second maxillary molar. I mean, if you run your tongue along the inside of your cheek near your upper back teeth, you can usually feel that little mucosal bump.
You can, yeah.
But I want to pause on the routing here because I don't fully understand the biomechanical logic. Why take this specific angular route? Like, why travel horizontally all the way over the masseter only to take a sharp right turn and punch straight through the buccinator?
It seems counterintuitive.
Yeah. Wouldn't a more direct, deeper route from the deep lobe into the back of the mouth make more sense?
You really have to look at the functional engineering.
Yeah.
Think about what the buccinator muscle does. It's the muscle you use to maintain tension in your cheeks. You use it forcefully to blow out a candle, or if you play a wind instrument like a trumpet.
Right. It compresses the cheek against the teeth to keep food in the occlusal plane during chewing, and it resists outward pressure.
Precisely. Now consider the mechanics of a duct piercing through the contracting fibers of that muscle and then running obliquely under the mucosa before opening. The bichinator acts as a dynamic functional valve.
Oh, I see.
Yeah, when you increase intraoral pressure, like when a musician blows into a trumpet, or even when you blow up a balloon, the bichinator contracts heavily. As the muscle fibers tense, they physically squeeze the parotid duct shut. The oblique mucosal path also acts like a flat valve, pressing flat against the duct opening.
So it literally prevents backflow.
Exactly. Without this muscular valve mechanism, high pressure in the mouth would force air, or even bacteria and food particles, straight back up Stenson's duct and into the delicate glandular tissue of the parotid, which would cause massive inflation and subsequent infection.
That is a phenomenal example of structure in service of function. The muscle tone itself acts as a one-way physical valve. It is a dynamically protected pipe.
It's brilliant anatomy.
So, okay, that covers the physical plumbing. But if the gland is an active factory pumping out saliva, it requires a neurological signal to tell it when to turn the factory on. Let's unpack the secretomotor innervation, the autonomic wiring.
This specific wiring diagram is arguably one of the most complex nerve routing systems in the entire head and neck.
Really?
Oh, without a doubt. The signal to produce saliva is parasympathetic part of the autonomic rest and digest system. But here is the critical twist. The parotid gland does not get its secretomotor signal from the facial nerve, despite the fact that the facial nerve runs directly through the center of the gland.
Wait, really? It passes right through but doesn't turn it on?
Nope. The true origin of the secretomotor signal is the glossopharyngeal nerve, cranial nerve on X.
Okay, let me try to map this out because it involves a ridiculous amount of neurological hitchhiking. It's like a commuter trying to get from the suburbs to a very specific office building in the city center, and they have to change trains multiple times.
Walk us through the commute based on the text. Let's hear it.
Right, so the preganglionic parasympathetic signal starts its journey in the brainstem and travels out on the cranial nerve and IX line. It exits the skull, but then it immediately takes a specific branch called the tympanic nerve, which goes up into the middle ear.
Spot on.
It forms a plexus there and then leaves the middle ear as the lesser petrosal nerve. That's the first leg of the trip. But it cannot go straight to the parotid gland. It has to make a transfer.
The first transfer stage.
Exactly. It arrives at a synaptic station called the otic ganglion, which is sitting high up in the infratemporal fossa, just below the foramen oval.
And that is the crucial relay point. At the otic ganglion, those preganglionic fibers from CNIX finally synapse. They hand off the signal to the postganglionic cell bodies. The first train has reached the end of its line.
Right. Now the new passenger, the postganglionic fiber, has to catch a new train for the final leg to the gland. And the train it catches belongs to an entirely different cranial nerve system.
This is where the hitchhiking comes in.
Yeah, it hops onto the auriculotemporal nerve, which is a branch of the mandibular division of the trigeminal nerve, or V3. So it hitchhikes on V3, riding the auriculotemporal line backwards towards the ear until it finally reaches its destination, the parotid gland.
It is a masterpiece of spatial routing. The glossopharyngeal nerve originates the signal, the otic ganglion processes the relay, and the trigeminal system provides the physical highway to deliver the final signal to the gland.
Wow.
And clinically, if you have a lesion anywhere along that convoluted pathway, say a middle ear infection damaging the tympanic plexus or a skull-based tumor compressing the otic ganglion, you lose parasympathetic input to the parotid gland, leading to a decrease in salivary flow.
We should also establish that this isn't the only wiring entering the capsule, right? There are sympathetic fibers arriving as well?
Yes, there are. Sympathetic fibers arrive by hitching a ride on the arterial vasculature. They originate in the superior cervical ganglion in the neck and form a nerve plexus around the external carotid artery. So, as the external carotid artery courses directly into the parotid gland, it carries these sympathetic fibers with it. Their primary role is not to control the volume of saliva produced, but to cause vasoconstriction of the blood vessels supplying the gland.
Which can indirectly make the saliva thicker and more mucus-like by reducing the fluid volume?
Exactly.
And finally, we have general sensation, pain, touch, temperature.
Right. The fascial capsule and the overlying skin are innervated by the great auricular nerve, which is a branch of the cervical plexus, specifically from spinal levels C2 and C3. It courses upwards over the sternocleidomastoid to supply the superficial aspect of the bed.
Got it.
And the auriculotemporal nerve, alongside carrying those secretomotor fibers we just talked about, also provides general sensation to the deep tissue of the gland.
Okay, so we've covered the plumbing and the wiring dedicated to the gland itself. Now we need to look at the transit lines, the structures that are merely passengers passing through this anatomical crossroads. And the most famous, most clinically critical passenger is the facial nerve, cranial nerve, the seventh.
The facial nerve is the absolute defining feature of the parotid bed. The relationship between the nerve and the gland is the single most important concept in this chapter.
It really is.
The facial nerve exits the base of the skull through a tiny opening called the stylomastoid foramen, located exactly between the styloid process and the mastoid process.
And almost immediately after exiting the skull, it plunges directly into the posterior, deep aspect of the parotid gland. It dives straight into our expanding foam.
It does. And once it is inside the glandular tissue, it does not remain a single robust trunk. It begins to divide. It forms a complex branching network known as the parotid plexus.
So it splits up while embedded inside the tissue.
Yes. Initially, the main trunk typically bifurcates into an upper temporofacial division and a lower cervicofacial division. From there, it fans out, dividing further to eventually exit the anterior and superior margins of the gland as 5 terminal branches.
The famous 5, the temporal, zygomatic, buccal, mandibular, and cervical branches.
Correct. These terminal branches fan out across the entire face to provide motor innervation to the muscles of facial expression. They control the muscles that allow you to raise your eyebrows, close your eyelids tightly, smile, frown, and purse your lips.
I really want to hammer home the functional distinction here because it trips up a lot of students. The facial nerve is completely embedded inside the parotid gland. It branches extensively within the parenchyma of the gland, but it does absolutely nothing for the parotid gland itself.
Nothing at all.
Right. It does not innervate the glandular tissue.
That distinction is paramount. Secretomotor control comes from cranial nerve IX via the auriculotemporal hitchhike. The facial nerve is merely a passenger using the parotid bed as a transit hub. The gland essentially acts as a protective soft tissue housing for this delicate branching network as it crosses from the deep base of the skull to the superficial fascial layers of the face.
But nerves aren't the only passengers. This is a major vascular hub as well.
Oh, it is heavily vascularized. The external carotid artery ascends from the neck and enters the deep inferior aspect of the parotid gland. While it is traversing the glandular tissue, it hands off branches.
It's delivering supplies while en route.
Precisely. It gives off the posterior auricular artery, which provides the primary vascular supply to the gland itself. Then, still entirely within the substance of the parotid, the external carotid artery bifurcates into its 2 massive terminal branches.
Okay, what are they?
The maxillary artery, which dives horizontally and deeply to supply the deep face and nasal cavity, and the superficial temporal artery, which continues straight upwards, exiting the top of the gland to supply the scalp.
So the main arterial trunk supplying the external face literally splits in half while buried inside the parotid tissue.
Yes. And the venous drainage system is effectively doing the reverse within the same space.
Oh, right, converging instead of branching.
Exactly. The superficial temporal vein descending from the scalp and the maxillary vein returning from the deep face converge inside the parotid gland. They join together to form the retromandibular vein.
Okay.
This newly formed vein then travels downwards through the gland, eventually exiting the inferior pole to join other vessels and form the external jugular vein.
So just to summarize, you have a major cranial nerve splitting into 5 branches, a major artery bifurcating, and 2 major veins converging, all happening simultaneously inside the lobules of a massive salivary gland that is wedged into a rigid, bony suitcase.
It is an overwhelming amount of critical infrastructure.
Which is exactly why pathology in this region is so diagnostically and surgically challenging. The anatomy dictates the danger. Let's pivot directly into those clinical realities. I want to look at what happens when this topography breaks down. Let's start with a disease that perfectly illustrates the concept of the rigid suitcase: mumps.
Right, mumps. It is a viral infection classically caused by the mumps virus, which specifically targets the parotid glands, causing acute inflammation and edema. Yes. Now, in most areas of the body, when a tissue becomes inflamed, it swells and expands outward. But we must recall our anatomical framework. The parotid gland is enveloped in a tight, unyielding fascial capsule derived from the investing layer of the deep cervical fascia.
And this fascial layer is exceptionally dense. It does not possess the elasticity to accommodate rapid swelling. The suitcase refuses to stretch.
Cannot stretch. So as the viral infection causes the glandular parenchyma to swell with fluid and inflammatory infiltrates, the overall volume of the gland tries to increase.
But it has nowhere to go.
Precisely. Because the fascial walls are rigid, the internal hydrostatic pressure within the compartment skyrockets. The gland is trapped. This massive, acute increase in pressure forcefully impinges on the sensory nerves trapped within the tissue and stretched tightly over the capsule.
And we established earlier that those sensory nerves are the great auricular nerve supplying the overlying fascia and the auriculotemporal nerve supplying the deep tissue.
Yes. Because these nociceptive fibers are being mechanically crushed by the swelling against the unyielding fascia, the pain experienced by the patient is absolutely excruciating. It is essentially a compartment syndrome of the face.
Wow.
If you understand the structural constraints of the deep cervical fascia, you understand the exact pathophysiology of the patient's agony. And it explains a classic clinical symptom, why the simple act of chewing is so agonizing for someone with mumps or severe parotitis.
Because when you chew, you are contracting the masseter muscle and moving the ramus of the mandible. You are mechanically squeezing the already rigid, bony, and muscular walls of the parotid bed directly against a swollen, hyperpressurized, heavily sensitized gland.
You are actively compressing a compartment that is already at maximum pressure limits. The anatomy directly dictates the symptomatology.
That makes total sense. Now, this overlapping wiring also creates another fascinating and frequently confusing clinical phenomenon. Referred pain. Let's say a patient presents to a clinic complaining of a severe throbbing toothache in their upper molars. Or perhaps they have sharp radiating pain deep inside their ear, or aching in their temporomandibular joint, the TMJ.
Right. Very common scenario.
They are sent to a dental surgeon. The dentist takes a panoramic radiograph, tests the vitality of the teeth, and finds nothing. The teeth are pristine. An ENT examines the ear canal and the tympanic membrane. It's completely clear.
This is where a deep understanding of neuroanatomy and overlapping sensory fields becomes the ultimate diagnostic tool. The human cerebral cortex is remarkably adept at localizing a somatic injury on the surface of the body. I mean, if you cut your index finger, you know exactly where the pain is.
Sure.
But the brain is notoriously terrible at accurately localizing visceral pain or deep somatic pain, especially in the head and neck where the territories of various cranial and cervical nerves heavily overlap and converge.
How exactly does the central nervous system get the location so wrong?
We have to look at the pathways. The mandibular division of the trigeminal nerve, V3, provides sensory innervation to the lower teeth in the TMJ. But remember, a branch of V3, the auriculotemporal nerve, also supplies sensory innervation to the deep portion of the parotid gland.
Oh, okay.
Meanwhile, the great auricular nerve, originating from the upper cervical spine, supplies the skin over the parotid gland and the posterior aspect of the auricle of the ear.
So they share pathways.
Exactly. When the parotid gland is acutely inflamed, massive amounts of nociceptive pain signals flood the central nervous system via both the trigeminal and cervical pathways. These signals converge in the trigeminal cervical nucleus in the brainstem. The brain receives this barrage of signals from the V3 pathway and fundamentally misinterprets the origin.
Gets confused.
Yeah, it assumes, well, the V3 circuit is firing heavily. It must be coming from the usual suspect, that lower molar, or the auriculotemporal circuit is firing. It must be the ear or the TMJ.
So the brain blames the wrong anatomical structure because they share the same neural wiring harness.
Precisely. The nociceptive signals are crossing wires in the brainstem. This is why a astute clinician never just focuses on the site of the reported pain. If the teeth and the ear are healthy, you must look for the clinical clue that distinguishes occult parotid disease from a primary dental or otologic issue.
I would assume that clue is found at the other end of the plumbing.
It is. You inspect the oral cavity, specifically looking at the parotid papilla, that tiny mucosal opening opposite the second maxillary molar. If that papilla is intensely erythematous, red, swollen, or if you can physically express purulent discharge pus from the duct by massaging the cheek, you instantly know the problem has nothing to do with the tooth.
The pathology is upstream, residing in the parotid gland. You have traced the functional plumbing to locate the structural source of the referred pain.
Spot on.
Speaking of tracing the plumbing, let's discuss what happens when the pipes themselves get blocked. Salivary calculi or parotid stones?
Right. In much the same way a patient can develop mineralized kidney stones, they can develop salivary stones, known as siliths. Calcium salts precipitate and form solid masses inside the ductal system.
No.
When a stone lodges in Stenson's duct, it physically obstructs the flow of saliva. When the patient begins to eat, or even anticipates eating, smelling a lemon, for instance, the parasympathetic secretomotor reflex kicks in.
The factory turns on.
The gland begins vigorously pumping saliva into the ductal system, but the fluid has nowhere to go. The duct rapidly distends behind the stone, the gland swells against its fascial capsule, and the patient experiences a sudden, intense shooting pain in the cheek that peaks during meals.
How does a clinician definitively diagnose the location of that blockage using anatomical principles?
They utilize a diagnostic imaging technique called scilography.
Mm.
A clinician carefully cannulates that tiny parotid papilla in the mouth and injects a radiopaque contrast dye retrograde backwards into the ductal system.
Right.
The dye flows upstream, filling the duct and its intricate branches within the gland. When a radiograph is taken, the dye clearly outlines the internal architecture. If there's a calculus, the flow of dye will stop abruptly, revealing a distinct filling defect. This gives the maxillofacial surgeon the exact anatomical location of the blockage, allowing them to plan an extraction.
Plan an extraction. That sounds straightforward, but any surgical intervention in this region is terrifying. I want to spend some time on the highest stakes clinical correlation covered in this anatomy: parotid tumors and the surgical minefield of a parotidectomy.
Well, while the majority of parotid neoplasms, such as pleomorphic adenomas, are benign, their physical growth distorts the anatomy, and they still require definitive surgical excision. This procedure, a parotidectomy, is universally considered one of the most delicate, nerve-wracking, and technically demanding operations in head and neck surgery.
Because you are not simply resecting a discrete, isolated lump of soft tissue, you are operating inside the transit hub. You have to navigate the embedded passengers.
Yeah, exactly. You have to navigate the facial nerve.
The surgeon is essentially diffusing a bomb. You have a tumor growing inside the glandular parenchyma, and you have the facial nerve, the critical structure that allows the patient to blink, smile, and speak without asymmetry weaving a literal web completely through or around that expanding mass. How does a surgeon even approach this conceptually?
The structural relationship dictates the entire surgical philosophy. A surgeon cannot simply cut blindly into the gland to scoop out the tumor. That would guarantee facial paralysis. Instead, they must perform a meticulous, systematic anatomical dissection.
Where do they start?
The standard approach for a superficial parotidectomy involves making an incision just in front of the ear, extending down into the neck. They elevate the skin and the superficial muscular aponeurotic system, the SMAS, layer off the parotid fascia. But the critical defining step of the operation is identifying the main trunk of the facial nerve before it ever enters the diseased gland.
Oh, they have to find the nerve at its source, right where it exits the stylomastoid foramen.
Exactly. To find it safely, they rely on fixed bony and cartilaginous landmarks. They find the trigal pointer, a wedge of cartilage from the ear canal that points directly at the nerve. They locate the tympanomastoid suture line on the skull bone, which acts like an arrow pointing to the stylomastoid foramen.
Triangulation.
Yes, they identify the posterior belly of the digastric muscle. By triangulating these precise anatomical structures, they can isolate the main trunk of the facial nerve in the tiny space between the skull and the gland.
And once they have the trunk, the real work begins.
Yes. Using microscopic surgical techniques and a nerve stimulator to confirm identity, the surgeon must painstakingly trace every single delicate branch, the temporal, zygomatic buccal, mandibular, and cervical divisions forwards through the glandular tissue.
Millimeter by millimeter.
They essentially peel the superficial lobe of the parotid gland and the tumor contained within it off the delicate webbing of the facial nerve. They have to do this without stretching, crushing, or severing the nerve fibers.
Because the anatomical consequences of failure are immediately life-altering for the patient. I mean, if the surgeon's scalpel slips and severs the temporal branch, the patient loses the ability to raise their eyebrow or wrinkle their forehead on that side.
Yes.
If they damage the zygomatic or buccal branches, the patient loses the sphincter control of the orbicularis oculi. They cannot close their eye tightly, leading to severe corneal drying, ulceration, and potential blindness. They lose the ability to smile, causing the mouth to droop severely on the affected side.
It's devastating.
And total destruction of the main trunk results in complete unilateral facial paralysis and iatrogenic Bell's palsy.
The dense, interconnected anatomy of the parotid bed is completely unforgiving. A parotidectomy is the ultimate test of applied anatomical knowledge. The surgeon must deeply respect the crossroads because the functional outcome for the patient depends entirely on the surgeon's ability to navigate those three-dimensional relationships.
Okay, I want to pull our focus back slightly. We have thoroughly mapped the suitcase, the ductal plumbing, the autonomic wiring, the neural and vascular passengers, and the severe clinical stakes of surgery. Let's integrate this into the broader anatomical systems of the neck. Let's look at what is sitting immediately deep to the medial boundary of the parotid bed.
All right. As we dissect visually deeper into the neck, pushing medially past the deep lobe of the parotid gland and the stylomandibular tunnel, we encounter the styloid apparatus.
Right.
This is a fascinating architectural complex originating from that sharp styloid process of the temporal bone we identified earlier as part of the medial wall. It is traditionally conceptualized as 3 muscles and 2 ligaments, though the text primarily focuses on the muscular sling.
Let's break down the functional mechanics of those 3 muscles because they are a brilliant example of deep neck complexity.
First, you have the stylohyoid muscle. It originates from the posterior aspect of the styloid process and reaches down to attach to the hyoid bone in the upper neck. Because it originates so close to the stylomastoid foramen, it is innervated by a tiny branch of the facial nerve, CN7, just after the nerve exits the skull.
What's its action?
When it contracts, it pulls the hyoid bone superiorly and posteriorly, which is a critical mechanical movement during the act of swallowing.
Okay, so that's cranial nerve 7. What about the next one?
Second is the styloglossus muscle. It originates from the anterior part of the styloid process, and instead of going to a bone, it reaches forwards and blends directly into the lateral aspect of the tongue.
So it moves the tongue.
Yes. This muscle is innervated by the hypoglossal nerve, cranial nerve 12, which controls tongue movement. When the styloglossus contracts, it retracts the tongue, pulling it upwards and backwards, again, essential for pushing a bolus of food to the back of the mouth during swallowing.
And the third muscle?
The stylopharyngeus muscle. It originates from the medial side of the styloid process and dives deep between the superior and middle pharyngeal constrictor muscles to blend into the wall of the pharynx. Uniquely, it is the only muscle innervated by the glossopharyngeal nerve, cranial nerve 9.
Okay.
Its function is to elevate and widen the pharynx to receive the food bolus during deglutition.
Notice the incredible dense complexity of that tiny region.
Yeah.
You have 3 distinct muscles originating from the exact same tiny needle-like projection of bone, yet they perform 3 distinct mechanical functions, moving the hyoid, moving the tongue, moving the pharynx, and they are wired by 3 entirely different cranial nerves, 7, 12, and 9.
It perfectly illustrates how tightly packed and highly specialized the deep structures of the neck are.
Yeah.
It's a remarkable convergence.
Yep.
And we should also mention the stylohyoid ligament. This is a fibrous band running from the tip of the styloid process down to the lesser cornu of the hyoid bone. Anatomically, it is actually a thickened portion of the deep cervical fascia. It acts like a structural curtain, helping to divide the anatomical compartments, separating the parotid gland situated above from the submandibular gland situated below and anteriorly.
The text mentions a great clinical quirk regarding this ligament, actually. It doesn't always stay a flexible, fibrous band.
No, it doesn't. Sometimes the stylohyoid ligament can undergo cartilaginous change, or it can completely ossify. It turns to solid bone.
Wow.
Yeah. When a patient with an ossified ligament has a panoramic dental radiograph taken, it appears as this massive, terrifying white bony spike plunging down the side of their neck. It looks incredibly alarming on the X-ray film, but for the vast majority of patients, it is a completely asymptomatic, harmless incidental finding.
So it's usually nothing to worry about.
Usually no, only rarely. If it impinges on adjacent nerves, or the carotid artery, a condition known as Eagle syndrome, does it cause symptomatic pain or dysphagia?
Okay, well, if we push even deeper than the styloid apparatus, we hit the absolute vital core of the neck, the danger zone, the carotid sheath.
This is the critical highway connecting the thorax to the brain. Immediately, deep and slightly medial to those styloid muscles, you find a dense, tubular condensation of deep cervical fascia known as the carotid sheath. Inside this heavily protected tube, you have the internal carotid artery, the internal jugular vein, and the vagus nerve, cranial nerve hex.
Okay.
Furthermore, the last 4 cranial nerves, 9X, EI, and 12, all cluster tightly around the superior aspect of this sheath as they exit the jugular foramen and hypoglossal canal at the base of the skull.
I want to explore the philosophical divergence of the vascular system here, because we discussed earlier how the external carotid artery willingly enters the carotid gland. But the internal carotid artery does something completely different, and the structural logic is beautiful.
It is a profound functional divergence. The common carotid artery ascends in the neck and bifurcates. The external carotid artery takes the superficial, messy route. It willingly wades into the dense, dangerous, active crossroads of the parotid bed.
Right.
It breaks into multiple branches to supply the face, the scalp, the muscles of mastication, and the glandular tissue itself. It acts like a sprawling, low-pressure sprinkler system designed to irrigate a wide, superficial territory.
But the internal carotid takes the protected route.
Exactly. The brain does not tolerate interruptions in blood flow. Therefore, the internal carotid artery stays deep. It tucks itself safely inside the thick, protective wrapping of the carotid sheath, traveling alongside the jugular vein and the vagus nerve.
Safely bundled up.
Yeah, and crucially, it gives off absolutely zero branches in the neck. Its singular, dedicated mission is to ascend straight to the base of the skull, enter the carotid canal, and deliver an uninterrupted, high-pressure, massive volume of blood directly to the cerebral circulation.
Structure and service of function. The face gets the sprawling, branching external system navigating the physical hazards of the parotid bed, while the brain gets the deep, shielded, unbranched internal fire hose. It's perfect.
It really is.
Finally, just to complete our structural boundaries before we wrap up the main synthesis, we must briefly account for the posterior belly of the digastric muscle.
Right. This muscle forms the inferior and slightly medial boundary of our parotid suitcase. It arises from the mastoid notch, located on the medial aspect of the mastoid process right behind the ear. It sweeps downwards and forwards to a connective tissue pulley on the hyoid bone.
Okay.
Because of its embryological origin from the second pharyngeal arch, it, like the stylohyoid muscle, is innervated by the facial nerve. It operates right in the immediate physical vicinity of the inferior pole of the parotid gland, helping to elevate and fix the hyoid bone during swallowing and speaking. Its muscular bulk provides physical support to the floor of the parotid bed.
This has been an incredibly dense journey through the topography of Chapter 11. Let's formally synthesize our key takeaways before we move into our clinical scenarios.
Good, yeah.
First, the core framework. The parotid bed is an irregular, unforgiving anatomical crossroads defined by the rigid boundaries of the mandible, mastoid, styloid process and associated musculature. Second, the occupant. The parotid is the largest salivary gland, heavily lobulated, stretching from the superficial cheek deep into the crevices of the infratemporal fossa.
Right.
Third, the transit. The facial nerve C in the seventh is the most critical passenger. It passes through the gland, divides into 5 terminal branches, and poses a massive surgical risk, though it provides no innervation to the gland itself. Fourth, the functional wiring. The plumbing relies on Stenson's duct using the buccinator as a dynamic valve, and the secretomotor wiring is a highly complex relay starting at CNIX, synapsing at the otic ganglion, and hitchhiking on the auriculotemporal branch of V3. And fifth, the clinical reality. This exact anatomy perfectly explains clinical presentations. The rigid fascial capsule explains the agonizing pain of viral mumps, and the overlapping sensory nerve territories explain why a parotid pathology can manifest deceptively as a toothache or ear pain.
It all fundamentally comes back to spatial relationships. If a clinician can accurately visualize these structures in 3 dimensions, the seemingly bizarre clinical symptoms become logical, inevitable outcomes of the regional anatomy.
Which brings me to a final provocative thought I want to explore with you. A piece of structural reasoning to ponder for our listeners.
Okay.
We talked extensively about how the unyielding, tight fascial capsule of the parotid gland acts as the absolute villain during an inflammatory process like mumps. It refuses to stretch, it causes massive internal pressure, and it creates excruciating agony for the patient. But think about this spatial arrangement from an evolutionary biomechanical perspective. The parotid gland sits wedged right between the bony ramus of the mandible and the mastoid process. It is surrounded intimately by the masseter and the medial pterygoid muscles. Every single time a human being chews, talks, swallows, or grinds their teeth, those massive, powerful muscles are contracting forcefully, generating heavy mechanical shearing forces directly adjacent to the gland.
That's a lot of force, yeah.
If the glandular parenchyma was soft, yielding, and completely exposed, the delicate spiderweb branching of the facial nerve embedded inside it would be subjected to severe frictional crushing and grinding thousands of times a day. Is it possible that this rigid, unyielding fascial encapsulation, the very anatomical feature that causes such terrible agony during a viral infection, is actually an essential evolutionary adaptation? Like a protective armor required to shield the vital facial nerve from the violent, lifelong mechanical trauma of simply eating a meal?
That is a phenomenal piece of functional reasoning, actually. You are looking at the fascia not as a flaw that causes disease, but as a necessary mechanical shield.
Right.
The tension of the deep cervical fascia diffuses the compressive forces of mastication, preventing those forces from transferring deeply into the parenchyma where the neural plexus lies. The extreme pain of mumps, therefore, is not a design failure. It is merely the tragic, unavoidable side effect of a highly successful, completely necessary evolutionary armor.
Exactly. The structure protects the function until the system is overwhelmed. Okay, let's test how well we've built these mental models. We are going to move into our learning reinforcement section.
Excellent.
We are going to run through 5 rapid-fire clinical scenarios based on the anatomy we've just discussed. Scenario 1. A 14-year-old patient presents to the emergency department with acute bilateral swelling of the cheeks and a high fever. They are diagnosed with viral parotitis, or mumps. The patient is in tears, complaining of severe, sharp pain localized to the side of the face, which becomes utterly unbearable whenever they attempt to chew food. We need to identify the specific neural pathway transmitting this somatic pain. Is it A, the facial nerve, CN7, B, the great auricular nerve, C, the glossopharyngeal nerve, CNIX, or D, the hypoglossal nerve, CN212?
The culprit here is B, the great auricular nerve. Let's break down the diagnostic reasoning. We established that the intense pain of mumps is caused by hydrostatic pressure stretching the unyielding parotid capsule. The somatic sensory innervation to the superficial fascial capsule of the gland and the skin directly overlying it is provided by the great auricular nerve, which ascends from the cervical plexus. The auriculotemporal nerve also contributes to deep capsular pain.
Why rule out the others?
Well, the facial nerve, CN7, is embedded in the gland, yes, but it is a motor nerve to the facial muscles. It does not carry somatic pain fibers for the capsule. The glossopharyngeal nerve, CNIX, carries the parasympathetic secretomotor command to produce saliva. It doesn't feel the pain of the swelling. And the hypoglossal nerve, CN7, is entirely motor to the tongue, completely unrelated to the parotid bed.
Perfect spatial deduction. Scenario 2. A maxillofacial surgeon is performing a deep lobe parodidectomy to remove a large pleomorphic adenoma. As they dissect near the inferior pole of the gland, they must carefully ligate and divide a major venous structure that actually exits the substance of the parotid gland inferiorly to join the venous system of the neck. Which vessel is the surgeon isolating? Is it A, the external carotid artery, B, the internal jugular vein, C, the retromandibular vein, or D, the superficial temporal vein?
The surgeon is isolating C, the retromandibular vein. To visualize this, we recall the venous convergence inside the parotid transit hub. The superficial temporal vein descending from above and the maxillary vein coming from the deep face meet and merge within the parotid tissue to form the retromandibular vein. This newly formed vessel then travels down and exits the inferior pole of the gland to eventually contribute to the external jugular vein.
And the distractors.
Let's discard them. The external carotid artery is arterial, and it enters the gland from below. It doesn't exit downwards. The internal jugular vein is located deep within the carotid sheath, medial to the styloid apparatus. It never enters the parotid gland. The superficial temporal vein enters the superior pole of the gland. It does not exit the inferior pole.
Excellent. Scenario 3. During an anatomy dissection, a student is asked to identify the muscular boundaries of the parotid bed. They pinpoint a slender muscle forming part of the deep medial boundary, originating from the styloid process. The instructor notes that this specific muscle is innervated by a branch of the facial nerve, CN7, just after the nerve exits the skull. Which muscle is this? Is it A, the masseter, B, the stylohyoid, C, the stylopharyngeus, or D, the medial pterygoid?
The student has identified B, the stylohyoid muscle. Let's trace the boundaries again. The medial wall is defined by the styloid process and its muscular sling. The stylohyoid muscle originates from the posterior aspect of the styloid process, forms a key part of that medial boundary, and crucially, because of its proximity to the stylomastoid foramen, it is explicitly innervated by a branch of the facial nerve.
Why not the others?
The masseter muscle forms the anterior boundary over the ramus, not the medial wall, and is innervated by V3. The stylopharyngeus muscle does originate on the styloid process, but it is uniquely innervated by the glossopharyngeal nerve, CNIX, not 7. The medial pterygoid muscle resides deeper in the infratemporal fossa, and while the deep lobe of the parotid might approximate it, it is a muscle of mastication innervated by the mandibular division of the trigeminal nerve, V3.
Spot on. Scenario 4. A patient arrives at a dental clinic complaining of severe throbbing toothache in their right maxillary molars. The dentist takes bite wing and periapical radiographs, which show no caries, no bone loss, and perfectly healthy teeth. The dentist then retracts the patient's right cheek and notices a highly inflamed, purulent mucosal papilla in the buccal vestibule. To confirm the diagnosis of parotitis masquerading as a toothache, the dentist knows they are looking at the exact opening of Stenson's duct. Where anatomically does this duct enter the oral cavity? Is it A, opposite the first maxillary molar, B, opposite the second maxillary molar, C, underneath the tongue at the sublingual caruncle, or D, opposite the second mandibular premolar?
The correct anatomical landmark is B, opposite the second maxillary molar. This is a pure, unalterable topographical landmark that every clinician inspecting the oral cavity must know. The parotid duct travels over the masseter, pierces through the mucinator muscle, and empties exactly at the parotid papilla located on the buccal mucosa opposite the crown of the upper second mole.
Makes sense.
The first maxillary molar is simply the wrong tooth. It's too far forward. The sublingual caruncle underneath the tongue is the drainage point for the Wharton's duct of the submandibular gland, a completely different plumbing system.
Yeah.
And the second mandibular premolar is on the lower jaw, which is entirely incorrect for the parotid.
Last scenario. Scenario 5. A surgical resident is reviewing the vascular supply of the parotid gland prior to assisting in an operation. They know the external carotid artery enters the gland, but they need to identify the specific arterial branch that arises within the substance of the parotid tissue to provide the primary vascular supply to the glandular parenchyma itself. Which artery is this? Is it A, the ascending pharyngeal artery, B, the occipital artery, C, the posterior auricular artery, or D, the internal carotid artery?
The resident needs to identify C, the posterior auricular artery. As the external carotid artery wades deeply into the substance of the parotid gland, it gives off this critical branch, which courses posteriorly and supplies the major vascular needs of the glandular tissue, before the external carotid finally bifurcates into its terminal maxillary and superficial temporal branches.
And the incorrect options.
Looking at them, the ascending pharyngeal artery and the occipital artery both arise from the external carotid artery much lower down in the neck, well before the vessel ever reaches the parotid bed. And the internal carotid artery, as we extensively discussed, is safely sequestered deep in the carotid sheath and famously provides absolutely zero branches in the neck, let alone to the parotid gland.
And that comprehensively solidifies the anatomy. From the rigid bony borders of the parotid bed, to the complex parasympathetic wiring of saliva production, to the terrifying surgical reality of diffusing the facial nerve, we have thoroughly mapped the crossroads. So the next time you feel that sharp little twinge in your cheek when you bite into a sour lemon, just take a moment to appreciate the incredible structural orchestration, the plumbing and the wiring, firing flawlessly right there beneath the skin. Thank you for joining us on this exploration of the parotid bed. Keep questioning the structure and you will always understand the function.